Okay, good morning, all. I give this lecture every year. It doesn't get any more fun to talk about. It doesn't get any more fun to listen to, but it's one of those necessary evils that are very important when it comes to your practice and how you practice. Being a physician is very altruistic. We try to do what's right and what's right by the patients. But the ugly truth of it is if you can't bill and you don't bill correctly, you can't keep the lights on, then you can't help anyone. So this is one of those necessary evils that we have to talk about. And so we're going to kind of jump right into it. See if it'll. Financial disclosures. I am a consultant for 10X Health. I need to update this. I'm also a consultant for Stryker now, but they don't do anything in the. I'm not going to talk about their stuff, so we don't have to worry about that too much. I have no other financial relationships that will be discussed directly or indirectly or referred to in this presentation. A couple of disclosures on off-label use: autologous blood, bone marrow aspirate, concentrate, platelet-rich plasma, prolotherapy, sclerotherapy are not FDA approved for the treatment of joint, ligament, muscle, and tendon disorders or tendon disorders. But we do use them, and the research has improved significantly since this talk was made, but they are still considered off-label use. I do want to give credit to Dr. Evan Pack. I borrowed the majority of this talk from him with permission, and he did a really good job of kind of making it digestible. And I think that's what we're going to try to do today. So objectives: we're going to review the current procedural terminology, or the CPT codes most frequently used in sports ultrasound. We're going to become familiar with the procedural and corresponding documentation requirements for using these codes and understand how to properly code for off-label and unlisted procedures. This information is based on how the coders at university hospitals and I interpret the wording within the coding manuals and other relevant literature, and also reflects our experience with billing, coding, and documentation requirements. There are many interpretations that may exist for the same wording, and notable variability may occur between states and even within states with different carriers. So I strongly encourage all of you to share and review this slide deck with your coders at your new job. So that's what I did. Whenever I got here, I sat down with the billers and coders. We went through this slide deck and just to make sure that my interpretation jived with how things were interpreted here at university hospitals and even in Ohio, coming from Alabama. This also changes. So if you start to see denials or you start to have issues with your billers and coders, it may be worth sitting down with them again to say, hey, what's changed? So diagnostic ultrasound, we're going to start with diagnostic ultrasound. There's two main codes for diagnostic ultrasound. And guys, please feel free to stop me whenever you have a question. There are a lot of numbers in here, a lot of codes, and it's basically just terminology. So we will try to get through it as quickly and as painlessly as possible. So two main codes, 76881 and 76882. 881 is the complete diagnostic ultrasound, what is needed for each joint or each particular area of the body for a complete ultrasound can be found in the AIUM documentation. For a shoulder, it's 13 images that all have to be labeled. I'm not going to go through all of them. You guys should know most of them at this point, if not all of them, but you need all 13 of them. For limited ultrasound, you basically just need that couple of pictures, short and long, of what you are looking at and what you're trying to evaluate. It does not have to be a complete exam, but you do need the real-time imaging documentation, and you need to be able to store the images as well. So the documentation, you need a couple of things. Number one, the title, what you're doing. So this is a limited ultrasound of the left plantar fascia. You need an indication, pre-procedure planning for an ultrasound-guided percutaneous needle fasciotomy. And then the findings are going to be describing what you see. It's not a diagnosis. And so you don't want to say there is a tear. what you would say is the fibers are disrupted and there is a hypoechogenetic area within the plantar fascia, and then the impression would be your diagnosis. This is a torn plantar fascia. That's basically what you need. Those are the four main things, and if you have those, nobody's going to say too much. You can certainly include more, and if it is a complete complete diagnostic ultrasound, a 76881, you can say what is pathologic. The rotator cuff, there is a supraspinatus bursal surface, partial tear, partial thickness tear that can be seen in both short and long axis. But you do need to at least reference the fact that you did the rest of the exam in saying that the other images were obtained and unremarkable of the left shoulder. All right, moving on. You should not submit a diagnostic ultrasound code when the diagnosis has already been established, particularly if by another imaging modality. So if somebody comes in for left lateral elbow pain and they have an MRI that confirmed that there is common extensor tendonitis or tennis elbow, you can't do an ultrasound and diagnose it again. It's already been diagnosed. Now, you can do a diagnostic ultrasound if you're planning on doing a procedure further, but you would have to say in the indications, this is for pre-procedure planning, not for diagnosis, not for a diagnostic purpose. Second time you don't want to use it is when the examination is done in preparation for an interventional procedure at the same visit. So you don't want to do a diagnostic ultrasound of the knee and then do a knee steroid injection and use a bundled code. We'll go over that a little bit later. And then you also don't want to use it for the contralateral limb or structure if it is examined for comparison purposes. So say you're examining the UCL of the right elbow, you can't examine the UCL of the left elbow and say that it's normal and then code for that separately. All right, so 76881, a complete exam. We've kind of gone over most of this already, but that just kind of puts it into print. 76882, the limited exam. Again, what to scan here is the important thing. At least one specific anatomic structure. It needs clinical justification and should impact your clinical decision making. Well, that's not good. All right. I don't know what happened there. I just got kicked off for a second. Is everybody still there, and can everyone still hear me and see the screen?
Yeah.
Okay, sorry about that. So you want to make sure that you can say person came in after having significant pain in the back of the heel while playing a sport, concern for Achilles tendon rupture, and then the clinical decision making can be deciding on surgery or not. That's it for diagnostic ultrasounds. We don't do a ton of them here. I probably do, I think some of the newer attendings do more than I do. I do mine mainly for percutaneous needle tenotomy purposes. I think you'll see more and more diagnostic ultrasound as the technology continues to improve and the prices continue to come down. So now we're going to talk about interventional ultrasounds. Interventional ultrasound. So the first code we're going to talk about is for needle guidance. So 76942. This includes imaging, supervision, and interpretation, and is mainly for needle placement, whether it's a biopsy, aspiration, injection, or just localization. You can use it for all of those. It requires an indication. It requires a justification for the use of image guidance, requires permanent storage of the images, and completion of a written report describing the needle localization process. That's the procedure note. The procedure note should be able to stand alone and should not rely on other parts of the note to fill in details. That's a medical legal issue. If you don't have that, it doesn't really stand up in court to say Well, it was obvious from the rest of the note. The procedure note is a standalone note, or should be a standalone note. And so when you're writing it, you want to be able to describe it. So you need a title again, what you're doing. You need an indication. That indication should also identify the side. So left knee arthritis using ultrasound guidance due to body habitus and needle conformation. Positioning, you want to say what position they're in. You want to say your approach, superior lateral approach, just above the patella and short axis to the capsule and long axis to the needle. You want to indicate what medications that you're using. For us, we have to make sure that it used to be you could just say 2 cc's of depomedrol. Now you have to say how many milligrams, and that's for billing purposes. And then 2 milliliters of 1% lidocaine. You want to talk about any complications, and then what you've done as far as obtaining images and storing them. When can you not use a 76942? You can't use it with basically any of the joint injection codes, so the landmark-based joint injection codes. And the reason for that is that there is a set of bundled injection codes for joints and bursas. So I missed the golden age of steroid injections by about 1 year. So it used to be that you would get about $100 to $200 for ultrasound guidance for your injections prior to probably 2013, 2012, somewhere in there. The problem is that certain individuals would do a landmark-based injection, put the ultrasound on after they were done, take a picture of the needle and say that it was an ultrasound guided injection at $100 to $200 an injection, and getting and doing 1,000 injections a year, which is not a lot of injections. You could make an additional $100,000 to $200,000. So the insurance company stepped in and said, no, we're going to bundle these codes, and you get maybe an extra. We'll go over what you get extra here in a little bit, but you cannot bundle it because you have an ultrasound bundled code. So if there's a bundled code available, you have to use the bundled code. So the 20604, the 20606, and the 20611 are your small, medium, and large joint injections. Always remember to use your J code as applicable. You can also not use 76942 with your transforaminal injections, your facet injections, or your sacroiliac joint injections. Those bundled codes there all include image guidance and specify fluoroscopy or CT guidance. I will do some sacroiliac joint injections. I consider it to be part of the hip complex. And so I will bill a 20611. So you can do an image guided sacroiliac joint injection. You just cannot use the 7096 because that code says that it has to be fluoroscopy or CT guidance. Does that make sense to everybody? All right, good. All right. So why is this financially relevant to us, right? So if you look at the non-bundled code versus the bundled codes, and this is using AMSSM 2004 combined survey, new graduate data, 50 percentile for RVUs, or reimbursement per RVU is around $45. That hasn't changed much. So the difference between 20611, which is ultrasound guided, and 20610, and these are the UH numbers. These have probably changed a little bit, and I'm still trying to get the new numbers from our billers and coders, but it's roughly the same difference. It's about 0.31 RVUs per injection. So again, if you do 1,000 injections a year, you guys have been in clinic with me. I do about 1,500 injections a year. And if you look at all of them, they're all fairly similar. They're about 0.3 difference. And so that's an additional 310 RVUs. Multiply that, and you will make, that is not the practice, but you will make an additional $14,000 a year for doing ultrasound versus non-ultrasound. or landmark based. Once you get good at it, and if you have people in the office that can label the images before you store them, which needs to be done, you can be just as fast doing ultrasound guided as you can landmark based. I think it is more comfortable for the patient. I think they tolerate them better. I also think they feel that you're doing something special for them, and they like that because most of the injections that they've had done at other facilities don't use ultrasound, so they feel like they're getting more for it. All right. So interventional, why is this financially relevant for your practice administrator? So now we're going to look at the difference of what is reimbursed. So a diagnostic, ultrasound guided injection, sorry, an interventional ultrasound is going to pay about $32.50 more if you do 1,000 injections. That's an additional revenue for the office of $32,000, basically $32,500 in office revenue. You can justify almost all ultrasound machines with just this slide. So if you're practicing, if you go to your practice administrator and say, I need an ultrasound, and they're going to say, why do you need an ultrasound? Give them this slide. If you do 1,000 injections a year, if you do 1,500 injections a year, you can add another $15,000 to that. You should be able to pay for your ultrasound machine in 1 year. For most of them, some of the higher end ones, it might take you 2 years. But the lifespan of an ultrasound machine is 5 or 6 years. So after that, it pays for itself. If you get a butterfly machine, which costs about $2,000 plus some of the equipment and a yearly, you're going to spend maybe $3,000 total, and you can make almost 30 grand in the first year just off of the butterfly. You can do most things with the butterfly without any issue. So it's pretty easy to justify most ultrasound machines just based off of your large joint inject or your joint injections. That does not get into diagnostic ultrasound or any of the other things that you can do with it. So this is an important slide. You can use a 76942 in conjunction with other appropriate procedural codes. These are non-bundled codes. So the carpal tunnel codes, the tendon sheath codes, ganglion cysts, peripheral nerve blocks, planar digital nerves. Again, remember to include your J codes. And I will, I'll kind of get up on a soapbox here when we get into this slide a little bit. As a profession, we probably don't do a great job billing and coding. We get very little in the way of education on this throughout medical school, residency, but it is at the end of the day a business, and in order to help people, you have to be able to keep the lights on. It's difficult to try to rationalize billing and coding sometimes because of how altruistic we all try to be, or our nature of why we all got into this. But if you look at just about any other profession, they have no problems doing that. From plumbers to lawyers to anybody else. You have a plumber come in and you want them to take a look at your sink that's backed up. No problem. They're there. Hey, my shower's not running. They'll be happy to look at it, but they're going to charge you for both. We kind of say, yeah, we'll take care of as many things as possible. And we don't have a great way to bill for multiple systems discussed, and without going too far into the weeds on it, I'll kind of stop there. So it's important to do these appropriately. So why is it financially relevant for you to know which ones are bundled and which ones aren't? And also making sure that we're billing and coding and documenting correctly. So I've run into a number of people throughout the years that will bill their lateral hip injections or their gluteus medius tendon injections as a bundled code as a large joint. Well, one, you're not injecting the joint, you're injecting the tendon sheath. And that's because I haven't seen too many bursts. I've done a lot of lateral hip injections. I can probably count on two hands the number of times I've actually seen fluid in the bursa. They are almost all gluteus medius tendinopathies. And so we want to build them that way. Well, if you look at it just on the surface, a large joint injection bills at 1.1 and a tendon sheath injection, or the 20511, bills at 0.75. So on the surface, it looks like, well, okay, I can see why people are billing it as a large joint. They're going to get more RVUs. Well, the issue is that if you add the 76942, now you've got a difference of an additional 0.32 RVUs per injection. That's about $14 per injection. I do about 100 of these tendon insertion injections a year, maybe a little bit more. Just for billing correctly and one extra click, I can make an extra $1,500 a year. Not only that, but it is what you're doing, and it's not fraud. So be very careful with what you bill. You want to make sure that what you are billing can be utilized with a 76942 or the needle guidance. So we're going to kind of go from there. Questions about any of that? We're going to move on to modifiers here. So you can do these in quantities greater than 1 per day per patient, similar to our landmark-based, but you have to make sure that you have modifiers. Modifiers are what we use to say whether we're doing a bilateral procedure or multiple procedures. Multiple procedures you can use, but you have to have the distinct, not a 51, you need the 59. Because, and that's the reason for that, you have to use a 59. There are actually better modifiers to use, and for some reason at university hospitals, we don't use them. We're still using all the old modifiers. So now there's XE, XS, XP, and XU, separate encounter, separate structure, separate practitioner. So if you do one and somebody else does one, that's more of a intraoperative modifier, and we don't really need that. And then unusual non-overlapping services is not something that we're going to use. The ones that you're going to kind of see most is going to be that XS or the 59 modifier for separate structure. You can still use the 59 modifier, but you should only use it if a more descriptive modifier is not available. It's not available to us here. That's why we use this with two distinct procedures. XS on the CPT code associated with secondary procedure. You want to make sure that's the lower payment procedure, and we're going to go into that here. Holy cow. I don't know why my computer's doing this. Can everybody still hear me and see this?
Yeah.
Yeah.
All right. So we're going to go into a couple of scenarios here. First scenario, 2 injections, same patient, same day. Neither is a joint or a bursa. Both are ultrasound guidance. So one's going to be a peripheral nerve. The other one's going to be the tendon sheath. That's going to be the one that gets the XS. And then we're also going to do needle guidance with the peripheral nerve injection. The reason for that is the peripheral nerve is going to make reimburse significantly higher than a tendon sheath injection. So that's why we do the peripheral nerve as the main procedure. All right, two injections, same patient, same day. One is a joint, one is not. Both are under ultrasound guidance. So carpal tunnel, and that will go with the 76942. And then the second one is going to be a large joint with the XS modifier. Let's see. So again, you don't want to use this. You can't use 20611 for the large joint injection. Remember, that's the one that's bundled. So you have to use the 610. And that's because guidance was already utilized with the carpal tunnel injection. Does that make sense to everybody? All right, so the rationale behind that is if you do the 20611, which has the ultrasound guidance, plus the 205 2.6 and you cannot use the ultrasound guidance with the carpal tunnel one, you're going to make about 2.04 RVUs versus doing the carpal tunnel injection with the ultrasound guidance and then a non-guided large joint injection. The difference is going to be about 0.36 RVUs. So you're doing the same amount of work either way. You just want to make sure that you're being reimbursed appropriately for it. All right, scenario 3, large joint, or sorry, 2 injections, large joint, same day, both are joints, one's under ultrasound, both are under ultrasound guidance. So you're going to do the large joint as your bundled code, and then the small joint as the XS code, but it has to be the non-bundled one or the landmark-based one. This doesn't make any sense to me, but a lot of the things that happen in billing and coding and insurance does not make sense to me. The larger joints get paid more or reimbursed more than the smaller joints. I know you guys have all done small joints. It's way harder to get into a small joint than it is to a large joint. But the people that came up with this initially decided that the bigger the joint, the more the reimbursement should be. So that's what they do. So if you've got a large joint and a medium joint, do the bundled code with the large joint. And the rationale behind this is going to be there. And you can kind of see it's 0.55 difference. So that's a pretty significant RVU difference. Just by making sure you're still doing the same work, the patient's still getting the same care. It's just you're making sure that you're billing it correctly. Again, 2 injections, same day, same patient. Both are large joint but separate structures, i.e. a hip and a knee. Both are under ultrasound guidance. Large joint with guidance, and then the second one's going to be the non-guided with the XS. I do a lot of these, or I do a lot of multi-joint procedures. Some people won't do it because you get about 50% for the second joint. So you get paid significantly less for taking on the same liability, taking on the same challenges, utilizing your skills, employing your knowledge. And so some people won't do it. My rationale or how I've kind of made my peace with it is the goodwill or the PR that you get from doing both on the same day. And I used to tell people more at the beginning of my career than what I do now is that, hey, look, I'm only going to get, I'm going to get paid significantly less for this, but I don't want you to have to come back just to pay more when we can do it today. I think the PR there and the goodwill there and the word of mouth, whatever good word of mouth advertising you can get for your practice is going to be way better than the extra couple of dollars that you might make by bringing them back a second time. Scenario 4, to enjoy the bilateral joint, you're just going to use that 50 modifier. Again, you're going to get paid about 50% of what you usually get. Combining codes. So you can submit, this is another important slide. So the E and M code with the 25 modifier, along with the ultrasound codes for same day, provided that clinical justification is documented. So a couple of times that E and M codes cannot be used. Basically, if the procedure is planned, someone's coming in for the second in a series of 3 viscose supplementation injections, or even the first. Yeah, go ahead. Someone have a question? Nope. Okay. So the E&M codes can't be used if it's planned. So someone comes in for a viscose supplementation injection that you just talked to about viscose supplementation injections last, a week before, 3 weeks before. You really shouldn't, or you can't bill an E&M code with it. It would just be the procedure code. Same thing if if the procedure is requested by another practitioner. So if somebody says that this person needs a hip steroid injection for diagnostic and therapeutic purposes, I would rather have and you can talk to some of your partners, I would rather have them say, I'd like the patient to be referred to Dr. Flannery to be evaluated to see if they are a candidate for a hip injection. If they say they need the hip injection and that's why they're sending them to you, it makes it a little bit more difficult to justify using that E&M code on the same visit if you do the injection. Does that make sense to everybody? Again, combining diagnostic codes with interventional codes, it can be done provided there's documentation. So you can use a 59 modifier to the diagnostic code. So if you're doing a diagnostic procedure on a different body part, again, you can't use it for localization of anatomic sites for the procedure. And then all of the imaging ends and interpretation have to be included for all of those bundled codes. Unlisted codes. We're going to go through this pretty quick because these, again, are off-label. But the 0232T is what we use for our PRP injections, and that's any site, but it includes image guidance, harvesting, preparation when performed. So that's a bundled code for us here. It's going to include image guidance, and so you cannot submit any of the large joints bundled or any of the joint bundled codes. You can't do guidance with it. It is all included in that code. It also includes the injection, so you can't use any tenotomy codes. It includes obtaining and preparing the platelets, so you can't use any phlebotomy codes with this or tissue grafting codes. It's all included. There's no RVUs or standard Medicare reimbursement attached. That makes it difficult to know how many RVUs you need to get. When we started looking at this, the way we looked at it is, what's the profit off of it? So how much does the kit cost plus the time in the office plus phlebotomy and all of those things? How much is the patient charged? And then what's the profit? What is a reasonable profit share there? And then you break that down by RVUs. We came up with about 3 or 3.5 RVUs for ours. That's kind of what I've seen in talking to people around the country. Between 3 and 5 RVUs is kind of where you want to be for these. Some of it is going to depend on what your office or what your hospital system charges them. So if your profit is $1,000 and you're making $300 off of it, that's not great. That profit share shouldn't be 70-30 in favor of the hospital system. It should be closer to 50-50 because these are standard procedures. There's no variability in the reimbursement. The reimbursement is collected immediately, meaning if somebody comes in, insurance A versus insurance B versus self-pay versus insurance D versus no insurance is all going to get paid differently. And that's where RVUs kind of came from. So it could standardize everything and you didn't have to worry, or the practice didn't have to worry about, well, we're not going to treat these people because their insurance isn't good. That's not the case with these self-pay procedures with a lot of the with a lot of the regenerative medicine procedures. It's all set and it all gets reimbursed immediately. So there is no loss here. And so the profit margins are going to be stable and you should fight for how much you deserve there. Again, it's cash pay, right? Although the description of the code is for platelet-rich plasma, there is a note indicating for bone marrow aspirate stem cell injection, you're going to use the same code. Again, there's no standard RVUs for Medicare reimbursement. You can use ABN and attach a GA modifier for medical care for Medicare, but it really, you get into the weeds there and you're better off just doing it as cash pay. For therapy, I don't do a ton of this. Again, there's a code for it, M0076. I don't do any of this. I should say it includes guidance. There's no RVUs. And again, you can consider that GA modifier. Percutaneous needle tenotomy, I do a lot of this. This is the elbow and shoulder only, may be used as an office-based procedure, providing the following requirements are met. 18 to 20 gauge needle is used, repeatedly fenestrating the tendon. You can do some bone work. Most of these get a 90-day global code, so you cannot bill an additional code for the follow-up visits within 90 days. And you're going to use the 76942 for ultrasound guidance as applicable, and that should always be applicable for these, as it's not a bundled code. You can do all of these different codes for percutaneous needle tenotomy. You want to make sure that you document well, and you want to include indicating use of a scalpel to make an incision, that it is not a needle alone. You're going to talk about the division, incision, or dissection of tissue. You also want to avoid terms of division, incision, and dissection, which are not consistent with in-office needle tenotomy. If you're going to do that in a surgery center, you can certainly use those terms, and those are all of the codes that we use there. So some take-home points with this. All of these codes can be coded in an appropriate clinical setting with adequate documentation and justification. The 0232T code is a category 3 code that can be used with PRP, BMAC, or adipose, but no other code should be used with it. No CPT code exists for prolotherapy or stem cell injections other than PRP and BMAC. Those are cash pay, and you're going to have to figure out with your employer how the profits from those get dispersed. Some practice gaps here. We need further research to demonstrate the accuracy and cost effectiveness of diagnostic ultrasounds versus other musculoskeletal imaging. And I do think you're going to see ultrasound become more ubiquitous as the technology improves. We could use some large, well-designed, random controlled trials for newer ultrasound-guided interventions that may aid in efforts to justify CPT codes for these procedures and subsequent improved access to them for insured patients. I think we're getting there with some of these. Some of the references that I used. I want to say thank you to Dr. Peck for putting the work in, even though he does work for the evil empire. Thank you for your time. Getting to the end of the fellowship. Here's a little throwback from mine. And we'll stop sharing the screen here. All right. Anybody have any questions?
Or let's say you are doing a nerve hydrodissection and you're using something like D5, then you can still code just for the peripheral nerve injection, correct?
Correct. You could, so peripheral nerve injection and ultrasound guidance. So I can't remember off the top of my head what the code is for peripheral nerve guidance, but you could use that plus the 76942.
Got it. So they don't really care what you're injecting. They just care.
No, the J code is what you would inject. And so as long as you're J code, they don't care. All that is saying is that you are injecting a nerve and that you're using ultrasound for needle guidance. Those are the two things that those codes are saying to the insurance companies or whoever's paying the bills.
Got it. Thanks.
I will make sure you guys all get a copy of this. Does anybody have any other questions? I know this was riveting.
I do have a question. For the 10x follow-ups, how do you build those?
So there's a post-op code that it's your global code. And off the top of my head, I now with Epic, there's just a button on there that says post-op. I want to say it's like 9,000 or something like that. It's a 9,000 code or 99999, and that is that's going to be the post-op code.
Okay, thank you.
Yeah, and so again, it's interesting because different body parts have different codes. The vast majority of the 10X codes or the percutaneous needle tenotomy codes are going to be 90-day globals with the exception of the Achilles tendon. The Achilles tendon is a 10-day global. If you can't figure out what 90 days is or you think it's close, you can actually ask Siri, what is 90 days from 5/31/2024, and it'll tell you the date, and that way you kind of know where your global is. So it makes it easier than trying to figure it out on a calendar. Sorry if anyone doesn't use Apple. I'm sure there's a Siri for Androids as well.
Thanks for being inclusive.
I'm trying.
Thanks, Rob.
No problem. All right. Have a good weekend, everybody.
Thanks, you too.
Uh,
Thanks.